Great. Thank you, Jodie. Hello, everybody. Good evening, and thank you for joining us for this Spasticity Academy meeting. I'm Steve Ashford, and I'll be chairing the session today. We're talking about spasticity in practice, assessment, decision-making, and management. Just a few brief slides regarding information before we get going with this evening's talks. So these are our speakers. There's myself. I'm a consultant physiotherapist based in Northwest London. There's Lindsay Duke, who's an occupational therapist and associate AHP director based at Walkergate Park up in Newcastle. Wendy Hendry, who's an MS specialist physiotherapist in Norwich, and Elizabeth or Liz Keenan, who's a nurse consultant at the National Hospital for Neurology and Neurosurgery at Queen Square. So in terms of our content today, we're talking about our objectives. We're talking about being able to recognize and differentiate between focal, multifocal, and global spasticity in clinical assessment. And importantly, we're trying to get you to understand, for those where this might be newer, what spasticity is and what spasticity isn't, and how we think about it in terms of what should be managed. We're going to look at structured frameworks for decision-making and outcome evaluation. I'm going to talk about some of those principles, and then they're going to be picked up in case studies and examples as we go through. And we'll also think about opportunities for allied health professionals and the team in general for looking at medication monitoring and optimizing spasticity management. And indeed, for some AHPs, they may be undertaking that medicines management themselves if they're prescribers. Just a little bit of information. So we've got some other academy classes and master classes that are coming up. This is the MS Academy master classes in 2026. So if you're interested in that, please scan those QR codes. We've then got a leading MS care together, supporting nurses through transformative and challenging times. This is a session that's happening in December this year up in Glasgow. Again, there's a QR code there that you can scan. And then we've got the National Neurology Transformation Meeting in 2026. This is aimed primarily at commissioners, but also involving clinicians and looking at neurology delivery transformation. And again, if that's of interest to you, there's a QR code for further information. So I'm going to start us off and talk about assessment and decision-making in spasticity management. These are my disclosures. So the learning objectives for this specific session is to refresh or expand knowledge on different methods of assessing patients. I'm going to talk about some basic principles that a lot of you will have heard of before, but I'm going to slightly challenge the way that we're thinking about this, and also explore decision-making and some of our measurement approaches in the context of spasticity. So just a sort of reminder here about the features of spasticity. This is a paper that I've returned to recently in Practical Neurology, and it talks about the velocity-dependent nature of spasticity in some presentations, most, but not all. The clasp knife phenomenon, i.e. the giving way. If we passively stretch, we might initially find that there's a velocity-dependent response and a resistance, which then gives way. The information or the point that spasticity responds to stimuli. So if we've got noxious stimuli such as pain or a full bladder or constipation, we might get significant exacerbations of spasticity. And then this distribution issue, which is really about thinking about how does the spasticity present, what muscle groups are involved. So before we think about anything in terms of spasticity management, we need to be relatively clear that we have got spasticity that needs to be managed. And then we can think about the distribution. But that decision about is this spasticity is really key for us. And the distribution of that spasticity becomes much more important when you're thinking about what management approach is. Should this be a generalized systemic agent that we're thinking about, or should this be a focal agent such as botulinum toxin? And if it's an agent like botulinum toxin, then we need to think, okay, where are we going to inject it? Which muscle groups? But that's only relevant once we've identified that we've got this problem in the first place. So I'm going to use the World Health Organization classification, international classification of functioning disability and health. And I'm really going to talk about systems impairment in terms of that decision-making about whether we've got spasticity and whether we've also got alongside that contracture or shortening in muscles, which may also have spasticity. I'm then going to talk about the activity limitation impacts that we might see, and maybe touch a little bit on participation in some of the tools later on. But that's not going to be the main focus of what I address today, although in some of the case studies we will pick up some of those issues. So first of all, just to think about that systems or impairment level issues that we present or that are relevant to spasticity. And we're thinking here primarily, not entirely, but primarily about spasticity and range of movement. So if we think for a minute about the impact of spasticity, well, we might want to think about whether range of movement at a particular joint is limited. If we suspect spasticity in a muscle or a muscle group, is that limiting range of movement, or have they lost some range because they've developed muscle shortening or contracture? And it's really important that we try and differentiate between what is spasticity and what is structural change in the muscle. So for example, if we've got spasticity and we inject botulinum toxin, that's likely to get a response and we'll get a reduction of spasticity. However, if we've got shortening in the muscle and structural change, the muscle has become more fibrotic, then if that's all that problem is, then it's not likely to change if we inject botulinum toxin. So you can see that differentiating between those issues is important. Often with the patients that we see, it will be a combination of those things, but we still need to be clear and think about both elements of intervention. So sometimes we might consider assessment, when this is really difficult, we might consider assessment under an anesthetic or a local nerve block, or we might support that with things like electromyogram or needle electromyogram to specifically test muscles. And for a lot of people who are perhaps referring into spasticity services, those things may not be available, but it's still really important to consider, is spasticity the problem here? Do I think it is? Is that the question I'm asking? And if it's not, what other things do we need to consider, or do you need to consider for that individual? So you can see that both spasticity and change in muscle structure will impact on range of movement. And we need to also consider that and probably measure it. And then lastly, think about the impact on function, because at the end of the day, we need to think, why is this important for the individual? So probably everybody will have come across the modified Ashworth scale. It's a measure of resistance, not spasticity as such, although it was conceived as a scale to measure spasticity, but you can see it's primarily measuring resistance across a joint. It doesn't reference the speed of movement though, and it offers a measure of passive resistance to movement, but it doesn't identify the effect of speed or motion. And it's not exclusively measuring spasticity, so its validity is questionable in terms of it just measuring spasticity. And I think that's very obvious when you look at the scale. It's not particularly well correlated with other measures, particularly laboratory-based measures. and its numerical categorization is not, if you remember back, think back, it's not a standard scale. It's an ordinal scale at best, and at worst a categorization. So if we're thinking about a ruler, that's an interval scale. And clearly the modified Ashworth doesn't fulfill those requirements. And it's not reliable between raters, or indeed the same rater. So the reliability is not particularly good for the modified Ashworth scale, but it is easy to do. It's relatively quick and easy to administer. So it does give us some information. And if you think back to the point I was making about starting to work out whether this is an active muscle contraction or whether the muscle has become short and fibrotic, it starts to help us to do that. An alternative is the modified Tardieu scale, and this does look at the quality of movement and also the speed of movement and the angle where we get things like a catch. If you remember back to what I've already said in terms of that clasp knife phenomenon, Tardieu starts to help us think about that. But it's much more time consuming to do, and its reliability is still not particularly good. It's slightly better than the modified Ashworth, but it's not particularly good. So we do have problems with the scales that are available for us to use in practice as measurement tools, but they're very useful in enabling us to assess what's going on for the patient. And then we can mechanize essentially, and this has been done by a number of people, and in particular, Anand Pandian and colleagues who at this time were based at the University of Kiel. They've looked at using electromyogram, electrogoniometry, and force to measure the different components that are relevant to spasticity in presentation. So essentially mechanizing, in one sense, the Tardieu scale, therefore giving a much more accurate measure. So that would be a potential way forward, but that's challenging for us to deliver in practice if we're thinking about routine care of patients in stroke services or early supported discharge or community teams. This would be very challenging to do in every case. It would also be very challenging for those of us that work in spasticity clinics to do this routinely. So if we think about motor function very briefly, we've dealt with impairment-based issues or those system function, and actually motor function is another system function. And things like the 10-meter timed walk or timed up and go, or in the arm, 9-hole peg test, for example, they're all measures of motor function, which I just wanted to mention, not because they're brilliant at giving us lots of information for decision making about spasticity management, but in some instances they may be really key to evaluating the function, the performance problems, but they're not necessarily function in the way that people want to function and behave in the community or in their lives in general. So they're still a measure at many levels of impairment or body system function. So we need to think a bit broader than these tools if we want to evaluate outcome. And critically, if we want to think about why we're intervening for spasticity, we again need to think about, well, what is the impact of spasticity on the way people live their lives and function in their everyday lives? So that's why we want to go on and think about activity limitation and participation restriction to some extent. So one of the things that we developed a while ago now was the Focal Spasticity Index. This looked at goal setting using goal attainment scaling. And here we think about the possible interventions. So for example, therapy interventions, physical interventions alongside a pharmacological intervention in the form of botulinum toxin. And then we're measuring some of the things at a symptoms and impairment level. And here I've got the example of pain, which is another important element that we do need to consider. We've got stiffness, we've got involuntary movements, and of course we've got spasticity, which is not actually listed there. There's an assumption that it's included throughout. And then under activities, we've got active function, so what people do for themselves, passive function, care-related tasks, and obviously included in active function is mobility and balance. And then we've got participation, wider participation in a multitude of activities, which lead through to quality of life and cost effectiveness in terms of the interventions. So if we think about goal setting, why is that important? Well, first of all, we need to think about, have they got spasticity or not? We've talked about that issue, and where is that spasticity? And then we need to think about, well, is that causing a problem for this individual? And therefore, setting the goal is a really good way to have that discussion. So we need to discuss and agree with patient and family and with the team what the goal should be. And it needs to be something that's relevant and important to that individual and will help us think about, is spasticity as it currently presents a problem for them, and does it need to be managed? Because not all spasticity will need to be managed. If you think about a stroke population, up to 80% of them will have some spasticity. Not all of that necessarily needs to be managed or is practical to manage. But in a lot of instances, we probably mismanage or don't manage spasticity that is present, and getting people the right treatment when they need it is critical. The goal setting process also helps us have that discussion about the expected outcomes of treatment, and to think that through, and to have a discussion with patients and family about what to expect from treatment and intervention, and what they can expect to achieve with this package of care. And then we can describe and document it. We use goal attainment scaling for this process, so it enables us to evaluate at some level the outcome, but it all, in terms of the overall outcome, but it also enables us to have that discussion with the patient, family, between the team, so that we're setting clear goals. And in goal attainment scaling, we combine the goals to give a single GAS T-score, and that reflects the achievement of all the expected goals, and it provides a basis for comparison. It also enables us to account to a greater extent for individual differences, because there'll be a lot of variability with the patients that we see. This is the goal setting structure that we developed for arm spasticity, GAS arm. And this has domains, which in domain 1 is our symptoms and impairment, or body systems level. And this includes pain, involuntary movements and range of movement, stroke contracture prevention, which is a really important consideration here. And domain 2, passive function, those care tasks, active function, self-performance of tasks, and then mobility is a separate category in the arm, when arm spasticity affects the way people move, walk, and transfer. You can see some codes here on the domain side of this table, and those codes are linking it back to the World Health Organization classification, or ICF classification. And we've got a similar structure for leg spasticity, which includes the same domains and the same subdomains of pain, involuntary movement, range of movement, and contracture prevention in domain 1. In domain 2, we've just got passive function and active function, but active function is broken down into transfers and locomotion or walking. And then just to point out, we always have some goals that relate to cosmesis or body image, and therapy facilitation, so things that are a step along the way to perhaps achieving other goals. And then you're really useful to us when we are having these goal setting discussions with patients and their families is to look at the arm and leg activity measures, which are measures of active and passive function in the arm for the arm activity measure or ARMA, and in the leg for the leg activity measure or LEGA. And they're freely available to use from the King's College London website. And the link is up there, but they're very easy to Google and find. These measures measure what patients do, and I will show you the tools briefly in a moment. They're validated and psychometrically robust, and they're possible for patients, carers, and or the clinician to complete, support patients and carers to complete. So they're low impact in many ways, and often we will ask for people to complete them prior to coming to a spasticity appointment, and we will use the information to then help us have that goal setting discussion with them. So this is the first two subscales of the arm activity measure. Section A is caring or passive function, things like cutting fingernails or cleaning the elbow crease. Section B is independently completing tasks, things like opening a jar, picking up a glass, or brushing your teeth. And then in the latest version of the arm A, we've got section C, which is impact on your life. So it's getting a quality of life stroke participation subscale here, just 2 questions. And section D is symptoms, pain, tingling, weakness, and stiffness. So we don't try and ask people here about spasticity, because this is a patient-completed tool. It's asking them about stiffness, which for patients will include intrinsic stiffness and will include spasticity. But here we're thinking, right, what's the impact of this on what you want to do? So that's the context that we're asking the questions in. The leg activity measure is similar. So section A is that passive function element again, caring, things like putting on underwear, continence pad, cleaning behind your knee. Section B is active function, so transfers, walking over carpet, walking outside. And then section C incorporates symptoms and impairment and impact on your life again, but in a single section with multiple questions. So hopefully, following that, you've understood a little bit more about assessing patients and thinking, first of all, about, do we have spasticity? If we have spasticity, do we also have an element of muscle contracture or stiffness or fibrosis? And if we do, where is it? And what is the impact of that on that person's function or other elements of their care? So is it making care tasks harder? Is it making certain functional tasks more difficult for them? And therefore, should we intervene for it and try and address goals in that area? Hopefully that then makes the decision-making in the context of spasticity easier. Okay, I'm going to pass over to Liz, who will follow on with her talk.
Okay, thank you very much, Stephen. That's been really helpful, and I think it's a good segue into what myself and Lindsay are going to talk about now. Our section is just looking at applying structural frameworks to decision-making and looking at some of the outcome evaluations and real-world examples, so some case studies. So these are my declarations. So as a start, I thought I'd talk more generalized spasticity clinic and sort of talk about what we use in the generalized clinic, where in that clinic there would be a neurologist, a nurse, and generally a physio. And we very much start along the lines of what Stephen has explained to us today as well, was asking the patient what is their main problem. So very much an open question at the beginning of that review, seeing if it's spasm, if it's pain, if it's stiffness, if it's problems with walking or transferring or sleep. Then we will lead into how that impacts. So what is the impact of that on their 24-hour routine, or how they're managing their triggers. So we very much sort of have a structured framework that we use within that clinic. We're always keen to find out what's been tried before, what people have from a therapy point of view, if they've had therapy, when they've had therapy, how long ago, or what the intervention was, and then obviously looking at the spasticity medications, the ones they've tried or not, or the ones that they've found helpful in the past. And I think that's really important to sort of build into the hands-on assessment. So that's really key, and that fits in with what we've heard from Stephen as well. Pulling all that together at the end of a consultation, trying to come up with a summary and obviously recommendations, and then making sure that that is communicated back to everyone, patient and the GP and the community teams. So I suppose, as we have just heard, we always have to think about what is the goal. So what is the goal of what we're trying to achieve in seeing someone in a multidisciplinary clinic? And does the spasticity need treating? And that's a really, really important point for you all to consider, because sometimes it is the case that the spasticity, yes, it is impacting on the function, but you may find that there's positive and negative effects of that spasticity. So you really need to think about, is the function being helped by some of the spasms and aiding transfers, or is it hindering? So it's really important to put that together and actually think overall, what is your client's goal? As we heard, we know the triggers can aggravate. We know those afferent inputs can make everything worse with the spasticity and spasm. And that's highlighted with all the patients we see in clinic, where they're finding there's problems with their bladder, or there's a splint or an orthotic, or there's a bowel issue, or there's a pressure sore, or there's pain somewhere, or they're just their seating and positioning has not been optimized. So it's trying to think of all of those and assessing all those triggers. And it's really, I suppose, a well-being check to make sure that all of those areas are looked at each time, and they do need to be managed in the best way possible. And again, leading on to what we've just heard, looking at the objective and the subjective scores and those outcome measures, and building a bigger picture of what's impacting for the patient. So is it the spasm? Is it the stiffness? Is there tone? Do we feel tone? Is it very different when the patient actually, or their carer, move them in a very different environment and not in a hospital environment? Sitting posture is always really key, and it's often something we take pictures of, or patients come to us with pictures of how their sitting posture or their lying posture is impacted. So it's really important to look at all of that and build that into function, how much that helps, how much it hinders. So trying to pull all of that together, but also getting that subjective rating scales as well. And these are really, really helpful for us when we're coming back to review, which I'll demonstrate in the case study. Obviously, as we talked about, the goal, what are we trying to achieve, what it is the patient really wants to get out of this. So I thought I'd talk to you through a case study of Pat, a 54-year-old gentleman with secondary progressive MS. He's got a 20-year history, and these are his core morbidities. So he has overactive bladder, he reports significant spasticity in his lower limbs, he has constipation, he had a PE, he's an overactive thyroid. And then when we look at what he's done from a function point of view, if we just focus on the mobility, which was a big important point for him when we saw him in clinic, when we look at the trajectory and the timeline on that, in 2022, he was using an FES device and walking. Then things changed as he moved in 2 years later in 2024. He stopped using his FES device. And then in 2020, at the end of 24, unfortunately had lots of problems with his triggers, and he was unable to take steps after having quite a few hospital admissions with urinary tract infections. So now what he's able to do is manage with a Mo lift for transfers with the assistance of one, and he has a standing frame which he uses at home. I think it's quite telling to see what the medications he's on, and it's really important to notice here that baclofen, he's taking all of his baclofen at night. For him, the big problem was the nighttime, so that's really important to see why he was doing that and understand that. He was on medications for his thyroid, he was on medications to protect his tummy. His gabapentin was 900 milligrams 3 times a day, which is quite a reasonable dose, but he felt that this had significantly helped his neuropathic pain. He was on Fibrogel, and he was on mebeverabine for his bowel and his irritable bowel syndrome. He was on rivaroxaban because he'd had a PE a few years ago, and then he was taking codeine occasionally and paracetamol. From an assessment point of view, he was managing independently with his bladder. He did have urgency, but he didn't have any infections when we saw him. Bowels, as I mentioned, he was having laxatives. Skin was all fine. The pain had much improved with the gabapentin. No chest infections when we saw him in clinic, but we know he was susceptible because he'd had that risk, and I had a PE back in 2020. Sleep was a huge problem. He said spasms disturbed his night every night, which is why he was taking all his baclofen in the evening. He felt that his mood was stable, but at the same time, because of the fact that he was awake a lot of the night, it made everything very difficult the following day. He had a package of care and he had a 24-hour carer, but he was independent once he was in his chair. So he reported his scores, subjective scores, as pain 3 out of 10. He didn't feel the pain was a huge problem now, but his stiffness and spasms were 9 out of 10, and they were really, really difficult for him to manage. When we did the findings in the clinic, when we did his assessment, no real problems at his right hip or knee. There was tone at the left, and we could see that in grade 2 on the scale. He did have some brief low amplitude spasms triggered on the left leg, but there was no spontaneous spasms. So while he was sitting in clinic with us for the 45 minutes, we didn't see any, but we did trigger some clonus on assessment. So we were trying to think, okay, so we'll pull all this together. So his impairments, we know there was left leg weakness, and he was finding it difficult to position his foot and needed assistance with that. He had some upper body weakness, and his balance sitting was poor. But he felt that the spasticity in the left leg was the real problem. And there was some spasticity there. And the spasms, particularly when he got into bed at night, were an issue. We had bladder and bowel dysfunction, and the sleep was disturbed. From an activities point of view, as I mentioned, he was using a Mo lift. He could manage with one, and he could do he could get into a standing frame. He needed positioning for foot positioning for assistance of one. Washing and dressing was assistance as well. He was able to take and eat and drink okay, and he did fatigue dependent. He did manage to self-propel a little. He managed to leave from a participation. He'd leave the house about twice a week, going for shopping or meeting family. Wasn't working, but I had a home-based admin job in the past. So what was his goal? So his goal was to reduce the spasm in his lower limbs, to reduce the stiffness and allow it to be easier bed mobility, to sort of allow him roll and reposition and make it easier to get on and off the bed. He wanted to maintain his transfers. That was particularly key to him. But at the same time, he wanted to try and think, could he reduce the baclofen, or could he improve his sleep by thinking of a different medication? And I think that's really, really important, because we need to think his goal at that particular time was very much around sleep. So I suppose that gives us an idea about which optimization of the medications we should be looking at. Should we be looking at the timing? Well, he was taking it at the appropriate time. He was taking the baclofen at night along with the gabapentin, and that was not, but unfortunately it wasn't helping his sleep. We need to look at the drug choices that we have available, and the clonazepam he hadn't tried, gabapentin he was already taken. Tizanidine can sometimes be quite effective for spasms that he described. So we sort of looked at how we'd manage and how we would report this and the mechanisms of monitoring it all. So what did we do? Well, we saw him in April 2025, and at that stage we thought, okay, let's try a small dose of tizanidine and see if we can pull down the baclofen. About 4 days later, he rang the spasticity helpline saying he'd had a terrible few nights, he couldn't sleep, and he's gone back on his baclofen and he's stopped tizanidine. So then we decided, okay, let's do a telephone review. So we did a telephone review in May, and we started low dose, 0.25 milligrams of clonazepam at night, and we started to reduce his baclofen. Pleased to inform us, he then called us literally 2 weeks after he'd started this to say it was the best night's sleep he had in many, many years, so which was fantastic. But then we wanted to think about optimizing what he was doing and how we could manage that a bit better. So we decided to increase the clonazepam to 0.5 and keep reducing the baclofen. So we gradually reduced the baclofen, and then when we did a telephone call a month ago, he had managed to reduce that down to 20 milligrams at night, remaining on the clonazepam, which she was really pleased about. So I suppose from an objective and subjective point of view, subjectively he felt that his stiffness was way down. So he was 3 out of 10 for stiffness, 3 out of 10 for spasm. The fact that he was getting a good night's sleep with no spasm meant that he was less fatigued during the day, and he was more awake. And he was finding there was benefit in his upper body strength, and he was managing to do some more exercises. Obviously, he'd reduced the baclofen, which was great, but from a function point of view, he was able to do that bed mobility, so moving and repositioning in bed, which was really, really key for him, and that was something that was very important. So I suppose it's trying to think of selecting a medication to target the symptom, and I think that's really, really key, because starting off, we know he was on a lot of baclofen, but we were trying to see, was there anything we could consider from a spasticity medication point of view with a low dose to try and help? Could he tolerate? Could he manage to reduce one, increase the other? And I think there's some general rules, which I'm sure everybody's familiar with, but starting a spasticity medication, we always talk about starting low and going slow. And it's trying to think about how you see, does the medication give you an effect? If there's no effect, pull that out, try a different medication. If that affects it a little bit and helps a little, then could we introduce another agent? And again, repeating that process over and over again until we make sure that we get to the key goal. And in his case, thankfully, we did achieve that. Now I'd like to hand over to Lindsay. Thank you very much.
So obviously we've been having conversations as we go through. And what I'm going to try and talk about is, again, another case study where we're going to look a little bit more about focal spasticity. These are my declarations. So we're going to talk a little bit within our sort of my case study are really about, is it spasticity or not, which we've talked about. What are the active or passive impacts on function? What's the goal for treatment? As we've been talking about, it's really need to be clear about whether it's a focal spasticity, a multifocal or global, because that will help to guide your pharmaceutical interventions as well as your therapy interventions. And it's really important that you talk about the non-pharma options as well. So it shouldn't just be pharmaceutical and or botulinum toxin injections, for example, option for them. It's about thinking about everything else that's involved and really using the skills of the MDT. So this next slide really just gives you a bit of an idea about some of the things you might want to think about within your services or the process that you've got. Thinking about, is it spasticity or not? What is the impact of that spasticity on the person? Consideration and provision of treatment methods. So really having a wide look at all of those different options, pharmaceutical, non-pharmaceutical inputs, and also thinking about for yourself and your services, do you have those skills and abilities to provide that, or is that something that you're going to have to make referrals onwards to? Because I think we, as you probably know, we all work in completely different services, and we've all got different options for what we can offer in-house and also what offers we've got within our region. So I think it's really knowing your own region about what you can offer. For the patient, it's really important to be clear about what you're trying to achieve and set realistic and honest targets for them. How are you going to measure that? So that's where you're going to talk about how are they going to measure and understand whether it's made a difference for them, and actually how are we objectively going to do that, and what tools do we have to do that? So again, you'll see a wide range of the tools. Stephen started off with a good selection of what they've got. Liz has talked about some she's used, and I'll use some within my case study as well. And the other next bit is, don't expect that, well, we've done all of that, job done, fantastic. We've got to continue with that ongoing monitoring review. So we need to make sure that did what we did, provided the patient, did that actually achieve what we set out to do? And if not, then what are we going to do differently and how are we going to change that? And when person goes through particular life changes, so particularly in Lizzie's case with her case study, if we've got something like a deteriorating condition, then how will that change over time? Or if people are going through more stressful times, have an infection, or all those trigger factors become more problematic, then we've got to continue to monitor and review. So we're going to talk a little bit about George. This is George here, obviously given his permission so that he's happy to be a star. George was referred to us at Walkergate Park in Newcastle when he was 56. He's married with children. He worked first time as a salesman, so a lot of driving around going on. He was a volunteer football coach. Otherwise, he'd been absolutely fit and well, and this stroke came out of the blue. He was a previous professional footballer, if you can call playing for Dundee United professional. But anyway, moving on. He had, by the time he came to us, managed to return to work and to driving, but when he was having discussions with us, he said that obviously fatigue was a big issue for him, but also some of the physical impact of his stroke was actually having a bit of an impact on both of those. He had a right pachy with left hemi, and he came to see us in 2012. And what we have is our initial spasticity assessment clinic is an hours long assessment, and we have a rehab consultant, physio and occupational therapist involved in that clinic. The main issues for George when he came in was, obviously he didn't use this terminology, but he said, my arm keeps pulling up when I'm walking, and my fingers are tight. So that was the main issue for him. He didn't feel there was anything else a problem. He didn't feel anything else was having an impact. That was the main thing that was going on. So for him, it was very much a focal issue. So we also had a bit of a chat with George, not only about what was going on, but what kind of impact it was having. He was very clear. So back to this cosmesis and body image. He was so used to being really fit and well and healthy. And he hated the way that his arm looked. He felt it imbalanced him when he was walking. So although the spasticity when he's in his arm, when he was walking, he felt that because his elbow was bending up, he felt more unbalanced. He was also felt he was getting some shoulder and back pain because of that, because he felt he was altering his gait in order to try and rebalance himself. He also struggled to get his hand open for his hygiene and cut his nails. He felt his nails were starting to sort of dig into the palm of his hand. But we had a little bit of a dilemma, because he also sort of said, well, I've returned to the gym and I want to continue to go to the gym, and I'm sort of using my spasticity a little bit to help hold on to things. But he was also quite anxious that it was limiting his rehab potential. His mood wasn't great and had been low, and it had got a little bit better. And he did have some underlying flickers of active finger flexion and active elbow flexion, but nothing he could put into any function. So this is a very whistle-stop tour. So long story short, it was a focal spasticity. So the pharmaceutical component that we did is we provided him with botulinum toxin. In George's case, it was Xeomin, and we put injections into his biceps and brachioradialis. We didn't want to put them into all three elbow flexors because we didn't want to leave him with potentially too floppy or heavy an arm. And also he was involved in the gym, so we wanted to give him a little bit of stability around there. We put some into left FDS and FDP for his finger grip. And again, although he had quite severe to moderate spasticity in his hand particularly, we wanted to try and see whether we could leave a little bit of that tension so that we could continue with his going to the gym components. So his goals were to allow his left arm to be down by his side while walking, so effectively the reduction of the associated reaction. He scored gas as a -1, so he had a little bit of ability to do that. He could drop it a little bit, but not much. And we use a goal satisfaction scale where 0 is unable and unhappy to do. So he scored his goal satisfaction with that as a 3 out of 10. He wanted to ease opening of his hand for hygiene and nail care. I guess, again, gas -1 and goal satisfaction 2 out of 10. We carried out a 10-metre walk test because he said his walking was impacted. So with his stick, he was doing 26 steps in 17 seconds, and his elbow was pretty much sitting at a 45-degree of flexion. And we carried out the army, and as you can sort of see, we split it into all 4 sections. And section C, which there's the bother, the top score of that is 8, and he scored 8, so it really bothered him. We also used photos and videos as we went on. But we've also got to think about what the additional interventions we were, because we couldn't just go, right, we've had your injections, we've set the goals and go away. So we also provided George with a bespoke thermoplastic hand splint. We provided him with a bespoke lycra arm sleeve to try and see if increasing his feeling of his arm would help with some of the associated reaction as well. We reviewed him in orthotics clinic to make sure that there was nothing else that we could do to improve his gait. and he'd sort of been discharged, so he was sort of in a gap between any therapy at that point. So we referred him back to the community physio, mainly for things like core stability, and again, to have a look at his gait. We talked a lot about self-management education. He was keen, he was interested, he wanted to do a lot, so we wanted to get him really on board with doing a lot of it. Because of his mood, we referred to the local talking therapies, and George has continued to be involved with us as a team all the way through and is really keen to be involved in training, research. He was involved in the SCOL6D research, and he continues to attend with us on a 4-monthly basis, and he's now 69. But as you can sort of see, the goal review post his interventions is that his elbow's gone up to an 8 out of 10, his hand has gone out to a 7 out of 10, his 10-metre walk test has significantly improved, not only in speed, but also his elbow position when he's walking, and his bother, particularly the bothersome bit, has gone down from a total score of 8 down to 2. So it bothers him a little bit, but certainly not as significantly as it did before. So in summary, from our section, I think it's about having clear assessment of the problem, including its impact, choosing your treatment, thinking about, obviously we've got the global aspect, we've got the focal aspect, but you may well have those people in the middle who've got a pocket of different areas which is difficult, and how do you going to treat that? Decision about how you or they will know if treatment's been effective, manage the triggers, especially pain, which is a massive one for a lot of our patients. Really think about what else is needed other than the medication options. Can this be provided by you, or do you need to make onward referrals? And you need to continue this process. You can't just say wave goodbye. If things are being improved as things go along, you need to think discharge is going to come only when you feel as if you've solved the problem, because presentations might change. And multidisciplinary team intervention and getting patients involved and getting them educated is really key. That's my and Liz's contacts, and I'm going to hand you over to Wendy. Thank you.
Right, so I've got 15 minutes to try and convince you why it's really important for you to get involved in medication monitoring. Liz talked a bit about the medications that we use for managing spasticity. And I think sometimes, especially as AHPs, and sometimes even as nurses and doctors and GPs, we can often think it's somebody else's job to put these people on medications and monitor them. But in my experience of managing a lot of people with MS and spasticity over the years, is often something that is overlooked, even if people are reviewed. And hopefully by the end of these few minutes, I'll have convinced you to how important it is for you to get your head around these medications and how important it is for your patients as well. So here we've just got a lovely list of all the different medications that we tend to use. These are the oral spasticity medications. And I think it's really important, if you are an AHP, if you're a nurse, if you're anybody that's dealing with people with spasticity, to really get to grips with these medications and know about them and know the dosing of them. And I think it's so important because these tablets are not like antibiotics. They have to be tailored to the individual to get the very best out of them. And they have to be monitored really for their effectiveness and regularly reviewed. And that's not just saying, are you still on these medications okay? It's, are these medications still doing the job that they set out to do? Because I think as Stephen alluded to, muscles change over time. Spastic muscles change. A lot of connective tissue will often sort of replace muscle tissue. And so the nature of the muscle changes, and people may not need as much of this medication as they were on initially. And I think the important things for AHPs really, especially, is to understand that these drugs can actually help you, because they are incredible drugs and they could be very, very useful in spasticity management, but they can also hinder rehab. And they do that because they're not terribly selective. Their job really is to sort of weaken a lot of muscles, but they don't always just weaken the spastic muscles, they weaken every muscle in somebody's body. And so if you're trying very hard to rehab somebody and against a background of perhaps too much medication, or you're trying to rehab somebody with not enough medication to help them overcome some of that spasticity, then these drugs can very much work against you. So very, very important that you really engage with these drugs, because it is a balancing act, getting these drugs right, a balancing act for us as health professionals and for the patients themselves, who are ultimately the experts. Sometimes in the winter and even, or in the summer, as the season changes, people may need different doses. In the winter, when people are a little bit colder, they might need a little bit more medication. In a warm, hot summer, they might not need so much. So there's a balancing act to be done there, and that's where we can get involved. Because we need to manage these troubling spasms and spasticity with medication if that's appropriate. Obviously, it's only one thing in our toolkit, but often we're working in trying to rehab people using these medications as well to give us the best possible outcome. And it's the unwanted side effects which can sometimes even mimic disease progression in conditions such as MS. So sometimes we don't always know that people are on the wrong doses. And if you're not lucky enough to live in an area where you have access to spasticity clinics on a regular basis, people may not always be getting the expert help that they need. I'm just going to play you a video, a very short video of a patient of mine called Mary. And I think Mary's story actually encapsulates everything I'm trying to say about the importance of getting to grips with these medications.
My name is Mary. I've lived with MS for 50 years. I was diagnosed 30 years ago, and I live at home with my husband, and I use an electric wheelchair to get around. I've been in the secondary progressive stage for some 10 years. I want to tell you how the gabapentin both helped and ended my MS journey. I was prescribed gabapentin 12 years ago when my spasms were interfering with my leg movements. So gabapentin was a godsend, and it worked beautifully. Everyone, including me, thought my MS was progressing 5 years ago when I became incontinent. I had an appointment with a physio who immediately noticed gabapentin and questioned why I needed it. She suggested I should discuss this with my GP and reduce the dose gradually. So all of us worked together. Eventually, I came off gabapentin completely and found I was no longer incontinent. My spasms didn't return. I went from pull-up pants to normal knickers. I cried when I told the physio. Not only could I now feed myself, my arm was more useful, I was less tired, my voice was louder, my personality returned, and my posture was better. I could now use a standing frame and go out without embarrassment. Because I hadn't realised how gabapentin was affecting me, I had continued to take it, scared my spasms would return. I recommend that people who get to know how gabapentin works and that all medications are reviewed regularly. My physio has given me my life back.
Thank you, Mary. And I think that the real message that comes through there is that some of the deterioration, which was actually put down to progression of the condition, was actually caused by the side effects of the drugs. So if I tried to rehab that lady, if I tried to get her posture better, tried to get a voice a little bit better, tried to stand up, I couldn't have done any of those things because the gabapentin was working against me. So it could well have led to a lot of secondary complications, which actually Mary didn't need to have. So very important that we really, really get to grips with these medications. And in fact, another case study here was a lady who had been on 40 milligrams of baclofen for 6 years, had a bit of leg spasms, and her GP upped the dose to 60 milligrams just in one foul swoop. She then started falling at home. She attended A&E with suspected fractures. She couldn't do what she used to do. They called the falls team in. the OT came in, and in fact, the culprit was an ingrown toenail. So, you know, this is just a simple case of triggers not being looked at, or some healthcare professionals not having that expertise to make sure that the triggers aren't the thing that's causing the spasticity. So some people may be on or have been put on higher doses of medication recently, which may have caused things like falling and then all the sort of knock-on sequelae of that. So always make sure that you understand the medication history. Because we know that if people are on too high a dose, we could have weakness of muscle, which then prevents them rehabbing, prevents them transferring, may interfere with their balance, have so many problems which potentially, as I say, could mimic disease progression. So really, really important to make sure that the dose that people are on is the dose that is right for them. And obviously, if they're on too little, and that can often happen as well, especially if GPs put them on doses, they're often not titrated adequately. And so, you know, there's still hypertonia there, there's still spastic gait. And so they may be on these medications, but they're just on too small a dose. So again, very, very important. So how do you get involved? And you may say, oh, okay, I don't want to be a prescriber. I'm not a prescriber. I chose not to be a prescriber. But we can change the timing of doses without being a prescriber, because you can only change the dose itself as a prescriber, but you can get in touch with the people who have prescribed these tablets and work with them and feed back to them. So you can't titrate these drugs. That's the job of the prescriber. But you can make suggestions to them, work with them, and get back to them in the way that I did with Mary. So, as I say, you may well find, just as Liz's patient was taking all of his baclofen at night, because that's when he was experiencing his spasms, you may find that you want to change the timing of doses in order to make sure that the person is getting the best out of that medication. And we all know people who struggle to get out of bed with spasticity, lots of carers struggling to do personal care, and then the patient gets down to breakfast and has their medication. Whereas perhaps if they'd had it first thing in the morning when they woke up, before the carers arrived, the process of getting out of bed, doing personal care would have been much, much easier. So it's all about tailoring. And we do that by using a spasm diary, giving a spasm diary to people, making sure that we know when the spasms are, or the spasticity is interfering with their life, whether or not it is interfering with their life, does it need treatment in the first place, when they're taking their medication, what dose they're on, have they had things like the bowels open, does that make a difference to how they're experiencing their spasms in the week? So you're getting a lot of information which you can then use to plan with them and tailor these medications in order to help them get the most out of their function. Timing of doses, as I say, has a really, really important impact. So make sure that they are taking them at the right time to help them with their functional activities. And you can often use the spasm charts or spasticity charts to actually find out whether they are being tailored to when people actually need them. So in a very whistle-stop tour of monitoring medication, my take-home message really is that AHPs and anybody out there really who are seeing people with spasticity who are on antispastic medications, I think we all have a duty to our patients and to ourselves if we want to help patients to achieve goals, to help people monitor these drugs so that we can make sure that they are taking medicines at the optimal dose in order to assist us to rehab in the optimal way, and that they're tailored to individual needs, and that these spasticity medications are reviewed properly over time, not just sort of ticked off, yes, you're still on them, that's fine. Really making sure that people still need them and haven't done what Mary did, develop some secondary complications which just mimicked disease progression. So antispasticity medication definitely needs all of us. Very, very important. And thank you very much for listening.
Thank you, Wendy. Excellent as always, and thank you to Liz and to Lindsay for explaining more broadly spasticity management to us, and with a multitude of examples there. We're going to try and answer your questions. There are already quite a few, and we're going to dish those out between us. I will probably just kick off with a few which relate specifically to my talk or to general issues, and then I will ask people to respond to specific things. So there's a question about goal attainment scaling, or GAS, and is that possible to share? There's also a question further down about arm activity and leg activity measures. They are available on the Cicely Saunders Institute, King's College London website. You can download them. A number of people have mentioned that the latest version of ARM-A is not available on the site, and that is true. It will be going up shortly, but it isn't there yet, so look out for it and go back to the site. You can download those tools, and I think some of the links and things will go up, and probably the slides from this talk will be going up on the Spasticity Academy website. Questions about differentiating contracture or fibrotic change in muscle and spasticity. I spent a bit of time talking about this and thinking about how we measure spasticity in that context. So we need to evaluate when we get some kind of reaction when we're stretching the muscle. We need to move muscles slowly as well as quickly to try and differentiate, and we need to look at what range of movement is actually available. Those are all ways that we can start to clinically build up that picture. Sometimes it's extremely challenging to differentiate, and that's when things like blocks can be useful, examination under anaesthetic, and even needle EMG, which I mentioned before. We've then got a question on spasms and the difference between spasms in spinal cord and spasticity in stroke, difference in physiology and management. Lindsay, would you have a comment on that?
I think that you've really got to look at the impact on the patient, and I think ultimately it comes down to, if you're sort of talking about the neurophysiology of it all, then it's about where the driver is coming from. Obviously, the spinal patients is centrally driven from the spine, and we're getting that. Whereas actually the spasms for people with spasticity may not just be centrally driven. So they may have spasms in lots of different ways, and it depends upon also how people are defining what they mean by spasms. And I think of all my years of working, I think it's about getting down to the nitty-gritty about how people are defining their spasms and what that actually looks like. So I think some people say, I have spasms all night, and it may well be that what they're doing is that they're triggering the clonus that they have, and it shakes and it shakes and it shakes, and that might be upper limb or lower limb, and so there's a clonus component of it. But you've obviously got those patients who may have a spinal cord, who get their full body extensor spasms, things are rigid, and they're getting those rigidity spasms as opposed to any moving or clonus related spasms. So I think it's about assessing the patient, finding out what they're feeling, and if you can see what they mean by spasms, because it's always the way your toothache goes away when you go to see the dentist. About actually, can you see it and have you observed it, and can you trigger it so you can actually observe what's going on, and having that discussion. With regards to management, it's exactly the same, because what you're looking for is this something that's a global issue, in which case do we need to manage it from a pharmaceutical point of view and review it, but also look at things like positioning, seating, triggers, aggravating factors, all those kind of things. Exactly the same as if it's something that's more localized, that's being triggered by something, then can we actually manage that spasm? I don't know if any of the rest of the panel have anything else to add to that.
I think that's good, Lindsay, and helpful, I think, to our attendees. I'm going to move us on in the interest of getting through questions. We've got a question about the 10-meter walk test, which I managed in my talk. I think the primary thing to say there is yes, it can be a useful measure, but the main issue I'm trying to get across is that actually measuring at an impairment level beyond measuring range of movement and spasticity as well as we can, given the paucity of the measures and our time constraints, is probably not the most helpful focus. What we need to focus on is what are the patient's goals and what are the functional performance outcomes, so that activity level of performance that's important to patients and carers. That's where we need to think about evaluation. Perhaps I can send this next 2 questions to Wendy, if you wouldn't mind. Can spasticity be made worse by mobilizing? And you can inhibit, essentially summarizing the question, the next bit, you can inhibit or minimize spasticity or tone by weight bearing and stepping. Can spasticity become more relaxed or improve over time? So can it be made worse by weight bearing or mobilizing, and can it improve over time?
Yep. Okay. Well, spasticity is incredibly individual, as we know. It depends on whereabouts the lesion has occurred, whether it's in the cortical, whether it's brainstem, whether it's in the spinal cord. Yeah. So on the whole, but this doesn't always work. If people are weight bearing, yes, tone tends to decrease, and often because you've got such a big stretch there at the Achilles tendon, you're putting weight through the muscles, and yes, but unfortunately, after that period of weight bearing, and then perhaps you may want to try and walk somebody, that doesn't always translate then into sort of function afterwards. These are very individual. I think it's why it's so difficult, and so little research has been done on this, really, because it is so difficult to actually come up with a one-size-fits-all approach. I mean, some people might go on a motorized bicycle, and after 10, 15 minutes, their spasticity is really, really reduced, and their tone is reduced. And for others, it can make it much, much worse. So it's a really difficult question. I mean, that's a completely pathetic answer, really, because it's such a difficult question to answer. And I think what you have to do is you have to have this sort of toolkit round your waist with all these sort of things in it. Talk to people about their own activities of daily living, and when is their tone at its worst? What functions are they doing? What position are they in? What's feeding in to some of those reflexes? What's making it worse? And try and find ways of doing things much as easily as possible. I mean, we know that the position of the head can be incredibly important. So if somebody's trying to get out of bed in the morning and they look upwards in order to get hold of their headboard, in order to give them a pull over onto their side, the minute they've extended their head, they often get a complete extensor spasm reflex going through their body, and then very, very difficult to get out of bed. Whereas if they keep their head flexed, keep their trunk flexed, you can often then keep the tone in their lower limbs at a very manageable rate. So it's very much trying lots of different things with people and seeing what works. I'm sorry, that's a sort of rubbish answer, really, but there's no one size fits all, I'm afraid.
Thanks, Wendy. I think just to say, if you improve motor control, generally people's spasticity gets better, and certainly with people post-stroke, some of them will improve spasticity over time. It varies a lot, and yes, there's a lot of variability in the people that we work with. So we've got a question. I'm going to go to Liz. There's 3 questions, Liz. So I'll start you with the first one, and perhaps we can do relatively brief answers for them. Yep. So there's a question about to treat or not to treat. Is that something you would only consider further down the line rather than the acute stage?
To treat or not to treat, sorry, for?
To treat or not to treat.
Okay.
In inverted commas. Is this something you would only consider further down the line or and not at an acute stage.
Okay. No, I think we need to think about it at any stage. So I think that's sort of what we're saying today. A lot of what we do is looking at, I always like to sort of package it in the sort of risks, benefits, alternatives, or doing nothing. So we're always trying to think about in a particular structure to say, actually, do we treat with a medication, but what are the benefits? What are the risks? Should we just wait and watch for a little while? Are there alternatives? So it's really, really important that we try and keep all of that. So yes, there are times to treat, but there are also times to wait and watch and monitor.
Thanks, Liz. And then a couple of questions about specific medications.
Yeah.
Sativex, is that a consideration?
Yeah. Sativex, yeah, I saw that question. It's absolutely, yes, it is. And it is an option for a certain percentage of people. The clinical trials show that there was about a 50% response rate to Sativex. It's a spray that's given under the tongue or into the lining of the cheek. So basically it isn't swallowed. It can be very effective. However, there is a cost incurred, so it has to be agreed with the local team. So some places have something called a shared care, and that's between the patient, the GP, and the neurologist. But that is something that it depends on where the postcode really of where someone's living, if they can have access to it or not. There was another question which I want to jump in because it's a really good question from Gillian, and she was asking about a referral for the gentleman. Absolutely. When we started that whole process, as you probably saw the timeline, we started in April and we've gone to September. So it's a short period of time. In our experience, trying to get home review with OT or physio can be a little bit longer than that before we can get that review. But absolutely, he's totally engaged in the fact that now that things have improved, he's got a bit stronger in his arms. He really wants to engage in having OT and physio involvement. So we've started that process. Thank you for the question.
Thank you. We also have a few questions which are sort of nuts and bolts of what will happen. I'll perhaps and where information is available from. I'll come back to that at the end. There's a comment about being not forgetting about triggers for spasticity. So we've talked a number of times, I think, in all the talks about these triggers. We perhaps haven't highlighted them. There's a lot to cover today in a very short time, so we haven't highlighted that stage. But yes, if you look at the RCP guideline, for example, it highlights specifically, think about things that will exacerbate spasticity. They're not the primary cause of spasticity, which is neurological, but they will exacerbate spasticity. So we're talking about things like infections. We're talking about things like ingrown toenails that Wendy's mentioned. We're talking about things like constipation and UTIs. All of those things need to be considered because they will make things worse. And if you don't address them, you end up putting people on medication which they potentially don't need. So I think that's a very important point, and thank you for making that. There's questions about access to services. Yes, go for it, Wendy.
Oh, so I just saw a couple of, I think it's really important. A couple of people are saying it's not within an AHP's scope of practice, physiotherapy's scope of practice to mess around with medications. And a lot of people in their service won't do it because they don't think it's in their remit. It is in our scope of practice. If you talk to Pippa White at the CSP, anything which impacts our ability to rehab patients is within our scope of practice. Thanks, Steve.
I think that's a really important point, and I would reinforce that. I've also had lots of contact with Pip White at the CSP, who oversees this for us as a profession. And I am a prescriber, so I look at this from a prescribing point of view, but I think as therapists, we need to be thinking about the monitoring of medications, particularly in this area of practice, because actually that feedback, if you're not the prescriber, it's essential that you provide it because probably nobody else is going to. There are actually quite a few more questions, and I am just going to have a little look through. So there's a question. Lindsay, I'm going to send this to you, and I think this will be our last question that we're going to answer, but there's a couple of questions there about post for botulinum toxin intervention. and follow up with therapy and splinting. Can you just say a few words quite briefly about the context there and how we should be thinking about that?
Absolutely. And I'm just going to direct people to, again, the RCP guidelines, where we've actually talked about timings and stuff. So certainly the way it works for us is we provide botulinum toxin injections. What we would expect to see is within the next sort of 5 to 10 days, the toxin starting to take effect, and probably work in its peak about 6 weeks. So with regards to what should we be doing, we should be telling the patient what to look out for. We should be telling them to continue doing all of their stretches, their exercises, wearing their splints, managing their aggravating factors. And then what we offer for the first 2 cycles is we see the person back at that sort of 6-week period of time, so that then we can actually review when the toxin's working really well, did we hit the target, so that we can actually say we were effective or not, and that will help us for their ongoing treatment. That is also a fantastic time, if you're talking about splinting, to actually then get in there and have a look at splinting. But as I sort of said, it's going to be something that you're not going to be able to do that 6-week review with every single patient. We've got something like 720 a month. So you're not going to have the capacity to do that. So it's about educating your patient about what they can be doing and when they can be doing it. But certainly there's times for us from a therapy to get in, move things, get them to do their stretching, get them to use their splints, get them to carry out their exercises, do strengthening exercises, and think about what's the best time to put things in place like splinting.
Thank you, Lindsay. And thank you to all our speakers again, to Wendy, to Liz, and to Lindsay for all the input, and to the team from the Spasticity Academy who've made this happen and facilitated our speaking to you tonight. It's been really wonderful to do so. There are a lot more questions there, but we're not going to be able to have time to address them all individually. But what we've tried to do is enable you to understand the context and to address most of those themes, which I think we've done. Thank you for those questions. There's some really thought-provoking comments in there. Just remember that for us to manage spasticity effectively for people at whatever stage of the pathway they're in, we need to be clear that we have spasticity, and we need to look at management interventions that will help that spasticity if that's a problem, if that's causing a problem to that individual. And that will probably go along with other elements in almost every case of their management program, their rehab program, their physical management program. So yes, absolutely, task training, re-education, splinting, serial casting may all be relevant for individuals, but it needs to be looked at on an individual basis to make the decisions about what treatments are provided. So again, a thank you to all of our presenters, and a thank you to all of you for coming along. It's been excellent to speak to you, and we hope you've enjoyed it and got a little bit further along the pathway of managing spasticity. Thank you, and goodbye.
Thank you.
Thank you.
Bye.